you for joining us today at this webinar on hair disorders in people of color, where this is the second webinar in a series of 4 of the impact of skin color and ethnicity on the clinical diagnosis and in research. I am Dr. Lynn McKinley Grant. I'm an associate professor at Howard University College of Medicine, and we have come together to, and I'm also president of the Skin of Color Society, but we've joined together with the New England Journal of Medicine and Visual DX to present these 4 webinars that will make you as a healthcare provider or even as a patient more comfortable with understanding the skin, hair, and nails and how it affects your health. Next slide, please. I have had the honor of talking with Dr. Congressman Lewis a few years ago about the misdiagnosis of diseases in skin of color and how the arts might be of help. He informed me, he said, well, I've never heard of such a thing. So his philosophy is always to take action, and I feel that's what the 3 groups have done in this collaboration. Next slide, please. You've seen several slides before we started of this painting and collection of Dr. Byron Kim, an artist who does skin colors and portraits of using the forearm to detect the exact skin color, and he mixes colors together. This is very helpful to us as doctors, and I think we should work on using this. Next slide, please. We have here in the center one of his panels, and it's sort of the normal color. And we found that we would add red or to take out red and see what colors we got. Well, as you know, every mother can always tell when their child is sick or ill or has a fever, they're more red, or they're anemic and really not feeling well and there's less red. So these are 3 panels showing the one to the right. You could think of, we've all witnessed the murder of George Floyd, where his skin color changed from the normal to sort of a gray, blue, brownish color and with no red once oxygen and blood was removed from his skin. You've also seen pictures of people who have more redness in their skin, and we call it erythema. And there you can detect with the panel on the left, more redness in that skin. Next slide, please. But to diagnose diseases in the skin or diagnose health in the skin, you also need color is important, the background color, but morphology and location. So you can actually make some pretty good diagnoses just looking at the shape of lesions and looking at the location. Next slide, please. So this is just a comparison of allegedly normal skin colors in the panels of Byron Kim, but also the abnormal red areas where there's been inflammation. And you see the different shades of red there. You can't say there's just red, they're just different shades. Next slide, please. So one of the keys that I want you to take away from the next 3 seminars and webinars is to realize that skin is a vital sign. We use it to diagnose diseases and to give it a good clinical differential, but you want to do the location, the morphology, the color, and then with the history, you can come up with a good clinical differential diagnosis, which takes you to your final diagnosis. Next slide, please. So I would like to thank so much our sponsors and Visual DX, New England Journal of Medicine, and Skin of Color Society, and to special thanks to Zoom Video Communications for its in-kind support of this webinar series. And now it's my honor to be able to introduce our moderator and panelists, and someone I've known for many years, to Dr. Andrew Alexis. Thank you. He is the chair of the Department of Dermatology at Mount Sinai Morningside Hospital. He's also chair of the director of the Skin of Color Center. He is an author of 2 textbooks, over 90 articles. He's just made major contributions to medicine in many areas. Dr. Alexis, thank you for being here.
Well, thank you, Lynn. I'm absolutely thrilled and honored to be moderating this session. In addition to being a moderator, I will also serve as a panelist and be giving the first introductory talk. It really is a pleasure and an honor to be joined by 2 of the world's experts in hair disorders, whom I'll introduce after my talk. But before we begin, a couple of housekeeping notes. We have carved out enough time for questions and answers at the end of our presentations, and we would welcome discussion, so please be sure to use the Q&A box at the bottom of your screen usually for any questions that you may have during these next 70 minutes. You don't need to wait till the end to ask your question. You can ask as we're going along, and we'll save them for the end. So one more housekeeping note, this session is being recorded and will be shared with registrants afterwards. So with that, I'm going to begin our first presentation, where I'd like to sort of set the stage for our next 2 speakers and give a broad overview of hair disorders in people of color, and focusing especially on those that are more prevalent in this patient population. So when it comes to hair in people, hair and hair disorders in non-white racial ethnic populations, we see that when we look at individuals of African ancestry or Black populations, there are structural differences in the hair. We'll talk about that. There are differences in cultural factors, hair care practices, which are relevant to a lot of the things that we see. This also does affect how frequently we see certain hair disorders among patient populations of African ancestry, and we'll talk about that. And I'll touch on the common non-scarring and scarring alopecias that are more prevalent in populations of African ancestry. Next slide, please. When we look at the hair shaft specifically between populations, one stark difference is that the shape of the hair follicle in individuals of African ancestry with whose virgin hair is afro-textured, the follicle is curved, giving rise to a hair shaft that is coiled in shape and flattened in cross-section. Next slide, please. When we look at the structure of the hair shaft itself in afro-textured hair, it's been found to have increased fragility, increased dryness, a lower growth rate, a reduced hair density, and an increased number of spontaneous knots compared to other populations studied. Next slide. This is an example of the spontaneous complex knots that can occur, and it's shown on the left, and an individual of African ancestry, an electron micrograph showing this complex knot with fraying of the cuticle of the hair, and these can happen just spontaneously and have implications for hair breakage, especially with the force of combing through such a knot. Next slide. Beyond structure and function, there are a whole host of cultural variations with respect to hair care practices and practices to just help manage the hair and for aesthetic reasons as well. Next slide. So taken together, we have structural and functional differences. We have cultural skin and hair care practices that vary from population to population. And then, of course, we have variations in cultural perceptions and standards of beauty and health. And all of these factors interact to produce differences in the epidemiology, in the clinical presentation, and the quality of life impact of skin and hair disorders. Next slide. So when we look at the most common diagnoses that are observed in populations of different backgrounds, one of the key differences we see is that hair disorders are among the leading reasons for individuals of African ancestry or Black patients to see a dermatologist. In this single center study from New York City at the Skin of Color Center done a few years ago, we found that alopecia was a top 5 diagnosis. And you'll see in one of the other talks later today that this holds true in national data as well. Next slide. When we think about hair disorders, there are 2 broad categories, scarring and non-scarring. Next slide. And with respect to common causes of non-scarring alopecia, we have telogen effluvium as an example, which would be an example of a diffuse non-scarring alopecia where patients will present with hair shedding. And then we have androgenetic alopecia, which is more localized and follows a certain pattern, which we'll talk about. Next slide, please. So telogen effluvium, this is the patient that presents with the chief complaint of, I'm losing all my hair, or I'm suddenly noticing all sorts of shedding of my hair. Hair is coming out in clumps. That would be a typical way to describe it. So when faced with a patient like this, doing a hair pull test and identifying that you're pulling hairs from the roots, if you will, you're pulling telogen hairs that have a little white bulb on the end. You can appreciate that this is diffuse rather than localized and can be caused by a whole host of factors, from psychological and physical stress to medical conditions and to medications. So a thorough history with respect to medications, underlying medical conditions, and usually a serological workup for hematologic, endocrinologic, metabolic, autoimmune disorders, depending on the patient's history and overall presentation. Next slide. Now, these examples are androgenetic alopecia, which you can see that in contrast to the telogen effluvium, is localized. Where is it localized to? On the left, we have a female patient of color with androgenetic alopecia, and you can see clearly that the hair loss where the scalp is visible is localized to the crown of the scalp or the vertex, as well as the frontal midline scalp. And that is a typical pattern for androgenetic alopecia in women. In men, we can have the same pattern, but also a predominance of loss in the bitemporal area. Next slide. Now, while those 2 examples are non-scarring alopecias that can affect any population, I'd like to focus, and you're going to hear a lot about these from the other panelists too, about conditions that are clearly more prevalent and have a tremendous impact on patients with skin of color. Next slide. The first being traction alopecia, which is one we're going to hear about repeatedly. Traction alopecia is, as the name implies, is directly related to the tension forces, the traction on the hair shaft and hair follicle, typically seen on the frontotemporal areas, and styles including tight braids are a common culprit. Next slide. While in early stages, traction alopecia is actually non-scarring, in long-standing cases, it can actually produce a permanent scarring. So the importance of catching this early. Next slide. Another scenario that is in some ways related, in fact, in this case, directly related to hair care practices, is hair fragility with the diagnosis acquired trichorexis nodosa. Now, a patient like this typically presents as an emergency. This is kind of like a hair emergency, a trichologic emergency, as one of our leading colleagues describes it. So this patient might say that I'm suddenly losing almost all my hair or large patches of my hair, and then on examination one notices that the hair shafts are of varying lengths, and then there's this obvious patch at the back where the hairs are much shorter than anywhere else. On hair pull test, you'll notice that the hair shafts are very fragile and they'll brittle, and unlike telogen effluvium, they're not going to be coming from the roots. They will just break midway through the shaft and not have the little white bulb at the base. So this is how you differentiate. And this is related to hair care, to over-processing, if you will, from overexposure to heat or to chemicals, or sometimes both. Next slide. Shifting into scarring alopecias, and by scarring, this implies that the follicles are succumbing to fibrosis, and when there's end-stage scarring, this is permanent loss of that follicle. So a consistent theme I think you're going to hear from our panelists is the importance of catching things early diagnosis. Next slide. So one of the most common scarring, if not the most common scarring alopecia one will encounter in patient populations with skin of color will be CCCA, or central centrifugal cicatricial alopecia. This is one that disproportionately affects women of African ancestry and typically begins on the crown or vertex scalp and extends centrifugally, as the name implies. One of the key tip-offs that this is a scarring alopecia visually, when you look at this image in front of you, you see that if you look at the little dots which represent follicular openings or follicular ostia, the sort of the density of follicular openings per centimeter squared is less than would be expected. Or stated another way, the spaces between the follicular openings is wider than would be expected. And that's because some of these follicles have scarred. And the earlier we can detect something like this, the better. Next slide. Because unfortunately, we don't have the opportunity always by the time the patient presents to catch it early enough, and we might be faced with a very large area of end-stage scarring, as in this example. Next slide, please. Another example of a scarring alopecia that disproportionately affects women of African ancestry, although it can certainly affect men too, is discoid lupus erythematosus, or DLE. So clinically, this can present with localized, not diffuse, but localized areas of hair loss. And on close examination, there's more than hair loss going on. One can see, in this case, an erythematous scaly plaque with hyper and hypopigmentation, or we could just say dyspigmentation within the center of it. There's follicular plugging on close inspection, which you may not be able to appreciate on the screen. This can be seen alone or as a manifestation of systemic lupus erythematosus. Next slide. This is an example of more advanced discoid lupus. And so at this point, you can see that shiny white surface. The area has really scarred in the center. There's practically end-stage scarring there and much less hope for bringing hairs back for most of this lesion. But we can certainly prevent advancement around the periphery of this. And so treatment is certainly still indicated. Next slide. Now, shifting to a set of scarring alopecias that disproportionately affect men, this is acne keloidalis nuchae, which typically presents with multiple firm, indurated papules that typically are found on the nape of the neck or the occipital scalp. And in advanced cases, as I'll show in the next slide, can go well beyond just the nape of the neck and can even affect the vertex scalp and other parts of the scalp and induce scarring, extensive scarring alopecia in severe cases. Next slide. Another disorder that, again, is found predominantly in men of African ancestry is dissecting cellulitis of the scalp. This presents not only with patches of alopecia, but if one was to palpate these areas, and it may be difficult to appreciate on the photograph, but these are boggy nodules. They're boggy, suppurative nodules. They tend to be interconnecting tracts between them. You press on one nodule, and the adjacent one might fill up with fluid and elevate. These can be tender. They can be extremely uncomfortable and disfiguring for the patient. And thankfully, we do have anti-inflammatory treatments that do work for this. Next slide. So taken together, when thinking about hair disorders in people of color, some of the challenges that the folks on this panel and many of our colleagues around the world have been working on is trying to reduce disparities by working on earlier diagnosis, because delays in diagnosis can lead to an increased risk for long-term or even permanent sequelae, especially in the context of scarring alopecias. When we think about educational materials that our healthcare providers, both in training and even those out of training, depend on to advance their knowledge, unfortunately, a lot of the conditions we're talking about today have limited coverage in these materials, and that's another initiative that we're working tirelessly on. So closing educational gaps, which will ultimately improve care. And finally, very important, limited research, unfortunately, historically, and even to this day, the overall amount of research into these entities to better understand them and to develop new therapies is relatively limited. And as such, our treatment options are somewhat limited. But thankfully, we are at an inflection point and things are changing, and a lot more attention and resources are being placed here. And I think the future for the patients that suffer from these disorders is much brighter. So with that, I'm going to thank you for your attention and turn it over to our next panelist, a close colleague and friend from Wake Forest School of Medicine in North Carolina. Anyone who reads anything about alopecias, hair disorders, especially hair disorders in patients of color, will see Dr. McMichael's name as an author. She's just worked tirelessly her whole career, advancing knowledge and conducting research, important research to better understand scalp and hair disorders in people of color. So it's my pleasure to introduce Professor and Chair, Dr. Amy McMichael, who will talk about non-scarring alopecia in skin of color patients. Amy.
Thank you so very much, Dr. Alexis. This is my pleasure to be here and talk to you about this very important topic today. We can go to the next slide, please. So I'm not going to belabor this study, but this is exactly what Dr. Alexis presented, but on a national level, where we looked at the National Ambulatory Medical Care Survey database, and we looked at the top diagnoses for each ethnicity, as you see stratified here, to dermatologists. And let's look at the next slide. And what you can see is that we have acne at the top, which is the same for every ethnicity that we looked at. And if we go to the next slide, you can see that, go ahead and forward it to the next slide. You can see that it is clear that seborrheic dermatitis and alopecia are at the top of this African-American reason for visits to dermatologists. There were no other ethnicities that actually had alopecia even on their topic. So if we're having trouble moving, we probably need to try to move 2 slides now if we can. So basically what we know about this is that hair and scalp disorders are extremely important to this group of patients. And I'll be talking to you today about some of the most common ones that we've already just reviewed with Dr. Alexis, including hair shaft disorders or hair shaft fragility, as well as traction. And I'm going to talk to you about seborrheic dermatitis as well. And I'm going to talk about seborrheic dermatitis as well, because I think that this is so very important to understand, because it is underlying so many other of the disorders that we're talking about today. And I think really management is going to require an understanding of how all of these disorders interact together. So let's go on and move to the next slide if we can. So hair fragility, we'll go right into my data here. So let me show you, I wanted to show you a very up close picture. So this is electron microscopy of a hair shaft, where we're seeing a giant fracture in the hair shaft right through the cuticle. This is irreparable. Okay, once you get these microfractures and those knots that we saw earlier in Dr. Alexis's talk, we can't go back. So we really have to figure out ways to prevent this. Let's go on to the next slide. So I had a real interest in this. And so some years ago, I looked at a comparison study where we looked at 60 women, 30 Caucasian, 30 African-American women. And what we found, the upshot of what we found, was that broken hairs were significantly increased in the African-American women or women of African ancestry. And interestingly, we had also been running an exercise study where we looked at how exercise influenced hair care practices in African-American women. And without even this being a focus, the hair shaft breakage rose to the top, with 55% of those patients reporting breakage with just normal styling. So let's move on to the next slide. So you'll see here that it wasn't just us. It wasn't just us measuring, but it was also the perception of the patients. The patients understood that they had different hair shafts, that they had hair breakage. And so in 60% of the African-American women in this study, they reported dry hair. 67% of the Caucasian women reported normal hair. And African American women were over 10 times more likely to want to change that hair dryness, and they were 3.5 times more likely to experience hair shaft breakage. So these are their perceptions. And let's go forward to see how it actually turned out. So not only did we see the breakage that I described to you, but we also saw that hair shafts in terms of diameter are much larger in Caucasian patients versus African American patients. We'll go on to the next slide as well. And hair counts in a standard area of are also higher in Caucasian patients. Okay, and we'll go on to the next slide. And even in growth data, so how quickly the hair grows after it's cut in 24 hours is much quicker in Caucasian patients. So what we're seeing here is a few things coming together. The hair doesn't grow quite as quickly. The hair diameters are smaller. We have problems with breakage. So as you can see, we're building a story, a case around why we really need to take care of this fragility, because we don't have the density that we might wish to have to start with. So let's go on to the next slide. So this is, just one of the ways that you can see patients present. Sometimes they present after chemical damage because they've already got baseline fragility, but then a chemical kind of comes in and makes it even worse or causes it to become more noticeable, or even associated with other forms of scalp conditions that we'll be speaking about later. Let's move on to the next slide. So what are some of these damaging hair care practices that we can at least change? Because what we can't change is this underlying fragility. We don't understand exactly why it exists, but we can't change that part. But what we can change is what we're doing to the outside of the hair shaft. So what we can look at is chemical straightening agents. What we know about chemical straightening agents is that they actually remove what we call the monomolecular layer of fatty acids. They damage this very important part of the layer called the 18-MEA layer. And that is extremely important to prevent penetration of water into the hair shafts, which minimizes damage to the hair shaft. You think water is good, it's moisturizing, but actually allows the hair shaft to swell and become more damaged. So this is going to most likely cause catastrophic damage to the hair. Hair dyeing is less likely to cause catastrophic hair breakage, but the problem is people are using it more frequently, so you're going to get cumulative damage. We do know that things like bleaches and permanent colorants are certainly a lot worse than semi, permanent colors, as well as temporary colors. So we encourage our patients to think about those sorts of things. And thermal straightening, flat irons and curling irons are going to cause much more damage than blow dryers, especially with repetitive use. Let's move to the next slide. Now, we also have patients who want to give their hair a rest, quote unquote, from their chemicals, from their heat. So they often will use twisted styles. Unfortunately, what happens with that is sometimes the twists are too tight and pull too much. And we'll talk about some of the twisted styles and what they can do a little later. But what you can't get is breakage even from these twists, because the tensile mechanical properties of the hair is only recoverable at low and moderate levels. We understand we have this innate breakage issue, so we can't twist too much or you'll just get breakage. And combing and brushing seems innocuous, but what we do have is data about, too much combing, too much, rubbing of the hair shafts on one another, which causes fragmentation of the fibers. And we know that from previous studies. So let's go to the next slide. So what can we tell our patients? Well, always, remember that the patient is a full patient and they're not just a head of hair. And is there something systemic going on? Do we need to check their levels of thyroid, their nutrition, their iron levels, etc.? Because all of those potentially can play a role in breakage. But what we really need to learn about and teach our patients is give the hair a rest. Stopping chemicals, colors, relaxers for 6 to 12 months is key. It may be difficult, it may not be what patients want, but it is key. Placing a hair weave that is not tight maybe will allow, and will continue to allow hair care and scalp care is something to offer. Loose braids or a wig. And natural hair is great, but not if you're going to straighten it with heat and do tight twists, etc. So you want to keep the manipulation down. Serial trimming of hair has to be done. Patients don't want to hear about cutting your hair when they have breakage, but it's very important. Using heat protectants on the hair before styling with heat kinds of treatments, and layering of moisturizing regimens. So the shampoo must be moisturizing, the conditioner must be moisturizing, leave-in conditions, coating agents with dimethicone, all these things have to be used in together with the other recommendations that we're making. And you have to discuss with your patients that it's going to be a long wait for improvement because, as I said, once those fractures are there, they don't go away. So let's move on to the next slide if we can. So seborrheic dermatitis we'll talk about very briefly. It's something that we see very commonly in African American patients. We know from the data presented here that it's much more common in African Americans than in Caucasians and in Asian patients, and was in the third most common of our national database study. Move to the next slide, please. So it's an itchy, scaly rash that occurs in the scalp, but also in all the seborrheic areas of the body, eyebrows, eyelashes, face, oftentimes mid-chest. And you can see it with hypopigmentation. We'll go to the next slide. You can see a couple of other ways that it can present with hyperpigmentation, sometimes with hair loss in the frontal hairline. Let's move on to the next slide. So what is the experience of African American patients? Well, they come in, they say, I've got significant itching. Maybe they'll have pustules in the scalp, they'll have scaling, and they'll, oftentimes consider it normal because it's so common in them. They've had it all their lives, and they've also seen everybody else in their family with it. And it can be complicated by infrequent hair care, hair washing, hair shaft breakage because of the scratching, and thickening of the skin called lichen simplex chronicus from scratching so much, and inappropriate use of hair care oils and pomades. Let's move to the next slide, please. And I'm going to go through this slide completely, but what I've listed here are several oils that are very commonly used to sort of cover seborrheic dermatitis. And unfortunately, what we know about these oils is that they can be irritating to the scalp and oftentimes cause comedones or acne form lesions on the face. And so really avoiding these kinds of oils is very important. And we'll go through a bigger regimen for care. Let's go to the next slide if we can. So what do? We discuss frequency of shampooing. I recommend to my patients no less than every 2 weeks. And that is the pack that I make with them if I'm going to take care of their hair. Products for textured hair, moisturizing, as we talked about for the hair care, for the hair shafts, but using things like 6-parathione, selenium sulfide, tar, and occasionally ketoconazole, which is prescription for the scalp is what we recommend. Since conditioners can wash off these active ingredients, you can get conditioners that actually have the active ingredient, 6-parathione. And using topical corticosteroids and stopping the pomades and oils are very, very important for care for seborrheic dermatitis patients. Let's move on to the next slide, please. So we have an algorithm here. You can check that reference, but it kind of goes down, kind of the itching, flaking issue versus the hair breakage issue, and talks about how to manage your hair in each of those cases. And we'll move on to the next slide. So the last thing we'll talk about in my talk is traction alopecia, and we'll go on to the active slide if you can. Thanks. Prevalence has been estimated at around 1% in a London population, about 37% in South African population, 3.7, I think is what it's supposed to read there. And a much higher prevalence in women and girls of African descent. It's a very high risk of those using chemical relaxers and tight braiding. We've seen that in studies. And more than 80% with traction alopecia have experienced pain with their hairstyle. So that's tragic. Pain is our indicator of problem. If you're having pain, then you are having a problem, and that should not happen with hairstyles. And the mechanism is thought to be mechanical tension in the hair shaft, as Dr. Alexis gave us the information about it earlier. Let's move to the next slide. And you can see here a patient with significant traction in the frontal hairline, still some maintenance of hair, and then another patient with traction on the side of the scalp, the parietal scalp, just right over the ear with sort of a fringe remaining. So, is this permanent? Is it something that, you can reverse? Well, in some cases, if you catch it early enough, you can reverse it. If you don't catch it early enough, it's permanent. And that's why both myself and Dr. Nkosi Delova will be talking about it in our talks. Let's go to the next slide if we can. So there are treatments, and when we do treatments, what I usually recommend at first is decreasing the friction, the traction behaviors, because if you don't stop those, you don't get any improvement. I like to use anti-inflammatory treatments because that tension causes a little bit of inflammation right there underneath the skin. And so I use mid-potency topical steroids about 3 or 4 times a week. And I usually do about 2 or 3 rounds of intralesional Kenalog at 5 milligrams per cc. Sort of post-inflammatory treatments include topical minoxidil used off-label for this reason, like the 5% daily. You can also actually do surgical restoration for this area in patients who are interested in doing that. And you have to follow improvement with the photos. And there is still fragility of that hair regrowth. So that hair that regrows is not as hardy as hair potentially in the back or top of the scalp, but it's there and you have to treat it very gently, treat it with kid gloves once it comes back in. Next slide. So you can see, so some patients do lose that frontal area. And so if they do, oftentimes it will recur. It will regrow if you do the treatments as I outlined, but you have to do gentle hair care, but not everybody is this lucky. You have to do it and tell patients that, you know, your expectations are 50-50 on what's going to happen. Next slide. And some patients, as I said, are not so successful. So as you can see, this young lady didn't get regrowth with the treatments that we recommended. She was still doing hair bands to cover the hair. She was still doing nighttime wrapping, despite the fact that we talked about this. So hair care practices really do make a difference. And perhaps she wouldn't have regrown anyway because of just so many damaged hair follicles. But we have to at least try in our patients when we can. And I believe we're going to end there. Next slide. So history of product use is very important, and you have to determine when and how hair cosmetics may be problematic. Give patients alternatives to the poor hair care cosmetics that they're using. Discuss what gentle hair care really means. Discuss the long wait for improvement and check in with the patient at regular intervals to encourage good behavior, and become knowledgeable about stylists in your area who can help with good hair care and keep the hair shafts healthy. And with that, I'll go to the last slide. Thank you very much for your attention.
All right. Well, thank you so much, Amy. That was a wonderful overview of non-scarring hair disorders in people of color. We have time for just one question before we turn things over to our next panelist. So my question to you, Dr. McMichael, is how can we partner with other providers, even perhaps the hair styling community, other members of the community, to help get better early diagnosis for the disorders that you spoke about?
That's a great question. Thank you, Dr. Lesson. I think we have to talk to our colleagues. I think we have to talk to our colleagues in primary care about what we think about these conditions, either in this kind of format or going directly to departments, holding forums with our patients in the community, as well as talking with our stylists in the community. I think going to hair care shows once we begin, those sorts of things, again, is vitally important for everybody who cares for your hair to be all on the same page and to keep the hair shafts and the scalp healthy.
And I'll just add that I'm glad that you, in your slide that's shown here, you have a list of very helpful organizations that help support patients and advance research and awareness for a lot of the disorders that we're talking about today, including North American Hair Research Society, the Cicatricial Alopecia Research Foundation, or CARF, and the National Alopecia Areata Foundation. So thanks for including that.
Yes, my pleasure. I'm glad that we can get that information out there, because they all are wonderful organizations that do a lot for our patients, but also put a lot of work into research as well.
Okay, well, thank you. I think it's time to move on to our next panelist, and we will have some time for Q&A at the end. So if you could advance the next slide for me, please. It is my pleasure and honor to invite to the program our second or third panelist, if you include me, Professor and Dean of the School of Medicine in Durban, South Africa, Dr. Nkosi Dlova, who has really been a trailblazer in many aspects of her career, including leading to some major advances in our understanding of the genetics of scarring alopecia. So she's tuning in all the way from Durban, South Africa right now, where I think it's late in the evening. And so we really appreciate her staying up to tune in with us today. Dr. Dlova, if we can have, if the folks in the background can advance to Dr. Dlova's first slide, that would be great.
Thank you so much, Andrew, for introducing me and for that kind introduction. Pleasure to meet you guys at this time of the day. Well, what I will try and attempt to do this evening is to cover some of the cicatricial or scarring alopecias. Andrew and Amy have so eloquently described some of the conditions and non-scarring, and Andrew has gone through the whole spectrum of hair disorders in African Americans. So I'm gonna touch on traction alopecia, central centrifugal cicatricial alopecia, and lichen planopilaris. These are the three top scarring hair conditions that we see. We'll also touch on the approach to treatment, how do we prevent exacerbation of these conditions, and lastly, leave you with a take-home message. Next slide, please. There are, of course, other causes of, yes, thank you. So what do we mean by cicatricial alopecia? That is another word for scarring alopecia. And if you look at this picture on the left, this could be anything. This could be androgenetic alopecia, could be central centrifugal cicatricial alopecia, it could be lichen planopilaris, or it could be trichorexis, loss from chemical processing. So scarring alopecia really means a compilation of hair disorders that destroy the hair follicle, replacing it with scar tissue, which will result in permanent hair loss. So the hair loss can be gradual and it may be asymptomatic. If it is symptomatic, it may present with severe itching, pain, and burning, as well as small pimples that may be tender, that is painful, and progress rapidly. Next slide, please. So it's often that the patient will present to you concerned and worried about their hair loss. It's important for us clinicians and doctors to show compassion, listen with interest, and pay attention to the patient. Don't think it is acceptable for us to be dismissive and just push the patient and say, don't worry, your hair will grow again, or just stop doing this. The compassion and making eye contact and listening to the patient with interest is very, very crucial in the consultation. Next slide, please. So how do we classify traction alopecia? Traction alopecia, traction means pulling, as Amy has described. It can be marginal, that is, you see it on the hairline, or it could be non-marginal, where you get traction around the center of the scalp. Next slide, please. Now, what are some of the early signs of traction alopecia? Traction alopecia takes time. It doesn't occur overnight. It is cumulative pulling and damage and inflammation of the hair follicle. And if you look at the picture on the left, you can see the scalp is pulled and tented, and there's tenting. You see redness also on the edge, as well as small pimple, pus-like folliculitis lesions that you see on the right-hand side. And you can see how tight those braids are. So these are the signs, early signs of traction alopecia, and all of these will lead to damage to the hair follicle and loss of the hair follicle. Next slide, please. So as Amy also mentioned, if you feel pain or headache or tightness of your scalp, you need to do that kind of hairstyle. It doesn't matter how much it costs to do it, because it is not worth it if you're going to lose your hair. So the following are some of the treatments that we use for traction alopecia. And lately, we have also used platelet-rich plasma, which I'll show you some slides. I think Amy has also touched on the treatment of traction alopecia. Next slide, please. This is a patient who had traction alopecia, who's been treated with platelet-rich plasma and needling, and has actually shown good response to treatment, as you can see on the third picture after 60 days of treatment. Next slide, please. So how about lichen planopilaris? So this is a second condition that causes scarring or irreversible hair loss. And we classify it in two different forms. There's frontal fibrosing alopecia, which is very similar to traction alopecia, but I'll show you how these differ. There's also fibrosing alopecia in a pattern distribution. This may clinically present similar to a patient who has androgenetic alopecia or CCCA. Some of these patients will present with facial pigmentation, and others will not have facial pigmentation. Facial pigmentation actually is a clue to lichen planopilaris, and it may present up to 6 months before one picks up that the patient has got hair loss. Next slide, please. So the patient on the left has frontal fibrosing alopecia without lichen planus pigmentosus, meaning there is no pigmentation involving mainly the sun-exposed areas. However, if you focus on the patient on the right, you will see that the patient has got early loss of the hairline, which one can easily dismiss as a traction alopecia. However, the pigmentation that you see on the sun-exposed areas is a clue that you're actually dealing with frontal fibrosing alopecia. The normal skin color of the patient is that on the right-hand side, is that of the upper ear that you can see. Next slide, please. So what are some of the features, clinical features of frontal fibrosing alopecia? It's very important to make this distinction because frontal fibrosing alopecia is progresses very rapidly. And what we need to do, if we start treatment early, we can actually abort the rapid progression of the disease. So if you look at the upper arrow, you will see that there's white-like papules or scaling around the hair follicle. And that's what we refer to as perifollicular plugging. And then a term that was coined by Miteva and Antonella Tosti, the lonely hairs that you see on there or where the hairline was. Those are features that are typical of frontal fibrosing alopecia. Next slide, please. Again, if you look closely on the scalp, you will notice that there's some inflammation around the hair follicle as displayed by the arrows on the picture. There's also redness, which looks brownish in a patient who's dark-skinned. That's also typical of lichen planopilaris, not CCCA, nor androgenetic alopecia. Common pattern baldness, you're not gonna see that perifollicular plugging, you're not gonna see the erythema. And of course, you can see the shiny areas where there's complete loss of hair. Next slide, please. This is a patient who's had progressive hair loss due to lichen planopilaris, and this is what we call the fibrosing alopecia in a pattern distribution, FAPD. And this patient, again, if you take a closer look, you will still see the redness and perifollicular plugging that is scaling around the hair follicle. Next slide, please. What other clues can we look for if we want to differentiate between traction alopecia and frontal fibrosing alopecia? You must always look at the other hair-bearing areas. And most of the time, patients will not have even noticed that they've lost their eyebrows. And you can see the typical loss of eyebrows on both patients. On the left side, the arrow is showing you that. On the right-hand side, the patient has totally lost their eyebrows. And they'll give you all sorts of excuses for losing their eyebrows because they cannot link the condition to frontal fibrosing alopecia. And the patient on the right also has lichen planus pigmentosus, which is darkening of the face. Patients will always tell you, Doc, I feel I'm getting dark. It can be very subtle. Please don't be dismissive about that. Look out for features of lichen planopilaris, FFA, or fibrosing alopecia in a pattern distribution. Next slide, please. So this is an interesting patient who has both patterns. He's got the fibrosing alopecia in a pattern distribution. You can see there's hair loss on the central area, and she also has hair loss involving the hairline. The eyebrows were also totally lost. Next slide, please. So this slide shows the treatment of FFA and fibrosing alopecia in a pattern distribution. It's a very difficult condition to treat. You have to pick it up early and try and be aggressive in the way you treat it. And the patients, sometimes you are able to abort the disease such that there's no progression. However, sometimes we are unable to regrow that the hair that the patient has lost already. Hair grooming is very, very crucial because you need to talk about it. I'm not gonna labor on that. Amy has so beautifully expressed and explained to us what are some of the proper hair grooming habits that we need to teach our patients. And of course, those who have lichen planus pigmentosus, you also have to treat that, and we treat it the same way as we treat pigmentation or melasma. Next slide, please. Right. The patient presents to you with frontal hair loss. What are the things that you're going to look at? How are you going to differentiate between traction alopecia and frontal fibrosing alopecia? The patient on the upper scale shows there's no follicular plugging, there's a fringe sign in the middle slide, and there are no facial papules. Those are clues that we are dealing with traction alopecia. And the nice thing about traction alopecia is that it is a preventable disease. We need to educate our patients, and we need to educate our stylists not to pull the hair, not to make very tight hairstyles. And if you look at the pictures in the bottom, frontal fibrosing alopecia, you can see the lonely hairs on the left picture, and there's no fringe sign. And also there's total loss of eyebrows, as well as facial papules that you can see on the picture on the extreme right, and follicular plugging. And I must share this anecdote with you. The patient on the right, I saw, I think 15 years ago. This is one of the patients that I saw with pigmentation and frontal fibrosing alopecia. The patient lost all her hair. And at that time when she presented, we thought she had alopecia universalis or totalis, when in actual fact, the patient had frontal fibrosing alopecia, which progressed to complete hair loss. Had we made the diagnosis early, had we intervened early, I think we may have been able to save this patient. But at that time, that was when we were beginning to see an increased prevalence and incidence of this disease. Next slide, please. So the last condition that I'm going to talk about is central centrifugal cicatricial alopecia, which Dr. Alexis has also touched on. And you can see the different grades, the picture on the left, in the middle, and on the right. These are actually siblings. The patient on the left, when she was advised about the condition and the fact that it could be genetic, because this is the mother on the right, and then these are the siblings, she stopped relaxing the hair, she stopped pulling the hair. And 3-5 years later, she could maintain the hair. The lady in the middle, who is the sibling, continued with pulling the hair with relaxers and weaves, and the hair progression progressed much, much rapidly. Next slide, please. So when one encounters a patient with CCCA, it's important that you also examine the family members, because they may actually have the condition. So what is CCCA? It's a lymphocytic disorder that most commonly affects women of sub-Saharan African descent. Males have been reported also, but not as common as females. It starts at the vertex and progresses outward in an insidious and centrifugal manner. And most patients are totally asymptomatic, but some may present with itchy scalp as well as painful papules. As you can see on the picture on the left, you can see the red papules on the center of the scalp. And you see that if you part the hair in the middle, you'll find that the part is quite wider when it's supposed to be possibly the size of a toothpick. So this, if you see a patient like this, you need to refer these patients to the dermatologist for scalp biopsy and dermoscopy, so that you can abort the disease before it progresses. And this could be female pattern hair loss. This could be lichen planopilaris. Dermatologists will be able to differentiate between the 2 or 3 conditions. Next slide, please. CCCA can be quite perplexing and difficult to diagnose. Those who have dermoscopy, it helps to use dermoscopy, because on dermoscopy, you see a gray halo around the hair follicle. Of course, in lichen planopilaris, you will see follicular plugging as well as erythema around the hair follicle. So these are pictures of dermoscopy. Looking at the middle picture, that's a normal hair scalp. There's no inflammation, no redness, no scaling, and no accentuation around the hair follicle. If you look at the picture on the left, you can see that the zone around the hair follicle looks grayish, and it has a perifollicular halo. And of course, the picture on the right-hand side is a typical picture of lichen planopilaris, which can present as female pattern distribution or as frontal fibrosing alopecia. You can see the erythema and perifollicular perifollicular. Next slide, please. Dermoscopy is actually important in dermatology because it helps us to actually magnify and see the conditions and the inflammation, particularly for hair conditions. So if you have a patient and you're not sure you've done dermoscopy, you need to do a biopsy. It's very important where you choose the location of the biopsy. It has to be at the margin between the normal scalp and affected scalp. You do not do a biopsy in the center of the scalp because you're going to see fibrosis, and that's not going to help you in your diagnosis. Next slide, please. The treatment of CCA is as listed. You should refer your patients to the dermatologist. It takes time. You need to counsel your patients. They may not gain the hair back, but at least you can stop the disease from progression. Grooming is crucial. Again, it's not just giving the patient the treatment. You need to take time to explain how the patient should look after their hair. They need to be patient. The response can be protracted. However, what you can reassure the patient is that at least you can stop the disease from progressing. Next slide, please. So this picture shows the impact of modifying hairstyles in patients who have scarring alopecias. And remember, with all the scarring alopecias, any type of chemical or pulling of the hair will make the condition worse. Again, this is an example of a patient on the left who, after diagnosis of CCCA, continued with braiding, chemical relaxers, and weaves since CCCA diagnosis, which was 3 years ago, and the disease progressed. Whereas the one on the right, she kept her hair short, and you can see that there's a patchy area of hair loss with very sparse hair on the crown. However, the patient has been able to maintain, and the hair can cover the areas of alopecia. Next slide, please. So I refer to this as hair assassination. The patient on the left has relaxed the hair as well as pulling the hair, and thirdly, she's put extensions. The one on the right, she's got relaxed hair and it's got these heavy extensions on the hair. This is a great recipe for hair damage, hair loss, and fracture of the hair shaft. And this should be avoided at all costs. Next slide, please. So prevention. Amy has spoken about this. I'm not going to labor again. When you see hair loss, please refer to a dermatologist because time lost is equal to hair loss. No pain when braiding your hair, no tension, no headaches, and recommendations for loose hairstyles, change of hairstyles, and give your hair a break, let it breathe and grow. Next slide, please. This is a poster that we have come up with. If you're interested on this, I'm happy to share this with you. We've got this in our clinics, in our dermatology clinics, and patients can read and choose the best hairstyles for their hair that are not going to cause traction. Next slide, please. That's my last slide. And thank you to everyone for listening. And thanks to the panel for inviting me on this platform.
Well, thank you, Professor Dilova. Very informative overview of a complex subject of scarring alopecia. Thank you so much. So in the remaining just under 15 minutes or so, we're going to open it up to questions and answers to all of our panelists. And thank you all for submitting your questions. We've literally got over 100 questions, and we're going to try to get to as many of them as possible. First question, this is for Dr. McMichael, although it's certainly appropriate for both of you, but I'm just going to ask you, Dr. McMichael. Given that many of these disorders that we've discussed today are in some way linked to hair care practices in many cases, is there a culturally appropriate, culturally competent way to help guide the patient to adjust their hair care practices when you think they're playing a role in their hair disorder? How do you do it?
Well, that's a good question. I think it is easier for me to do it because I stand here as an African-American woman. I think that sometimes coming from people who are not of color, it's a little bit more difficult. And I think in that situation, you have to say, okay, this is the data that we have. This is not just our thoughts, what we think might be. I mean, we have data to show it. So you have options, and the options are loose hair care practices, not doing chemicals, or you can continue to progress. So you have to present it to the patient. It's their choice. I've had patients that have told me, no, I absolutely cannot stop my chemical relaxer. I cannot stop coloring my hair. And I just put it in their minds. I tell them that that's something that they can do and it will help. And, oftentimes they'll come back 6 months to a year later and they say to me, Dr. McMichael, I have found the way to help my problem. And I said, well, what is that? And they say, oh, I've stopped chemical relaxers. I've stopped coloring my hair. And you know what? I don't care if they think they came up with it themselves. That's fine. But put it in their brains, because they will actually ruminate over it later. You don't tell people, don't do this, don't do that, stop this, stop that. You say, these are your options. You choose. This is the way you can make your life better.
Mm-hmm. Great advice. And I found from my experience that it's often a journey. It's not an all or nothing. It's not an on-off switch in terms of stopping hair care practices and going off on a new path. It really it occurs gradually over time in many cases. So Dr. Delova, I have a question for you. This is from the audience. Something that you covered very well, but it would be great for some take-home messages. Traction alopecia and frontal fibrosing alopecia. They look very similar. How do you tell the difference?
Yeah, good question. It can be quite difficult to differentiate between these two conditions. But as I said, patients with frontal fibrosing alopecia, some of them will have pigmentation. You'll find that they're not coming with the hairline hair loss, they're just presenting with pigmentation, and you pick it up. So traction alopecia, you will not have the pigmentation. Secondly, the most important clue also is loss of eyebrows or very sparse eyebrows. You have to look for that because the patients may not even aware that the eyebrows are sparse. So the third one, some patients may have papules, skin, small bumps on the face, okay? And that you see with frontal fibrosing alopecia or even the fibrosing pattern. The fourth one is the hair fringe that I spoke about, which is almost always there in patients with traction alopecia. However, I don't see it in patients with FFA. The fifth one, if you want to go really dig down, if you look at the hair follicle, around the hair follicle, you're going to see the follicular plugging, which is, a sort of scaling around the hair follicle, as well as redness around the hair follicle. Sometimes it's not, you look for those and you don't find them. Best thing to do, you do a biopsy or you use a dermoscopy to pick up the signs. Thank you.
Okay, thank you. Very, very practical and helpful. Back to you, Dr. McMichael. This is an interesting question from the audience. Does the microbiota of the scalp or skin play a role in alopecias? The alopecias that are not necessarily directly caused by traction or chemicals. Is the microbiome important? Dr. McMichael?
I think so. I think we're learning more about that. And what I didn't really talk about with seborrheic dermatitis is how the Malassezia yeast play a role in that disorder. So these yeast that live on all of our scalps, in some people who make lots of oils, those yeast get very excited. They eat the oils, they kind of spit out what they don't like, and that causes the whole inflammatory cascade that initiates itching and scaling and that sort of thing. So we know, I think probably about a tenth or maybe a 20th of all we need to know about scalp microbiome. But I think that the microbiome of the scalp, including the yeast, including the bacteria, actually do play a large role and probably play a big role in the disorders that you mentioned, Dr. Alexis, with the dissecting cellulitis, folliculitis decalvans, and all of those sort of scarring processes, maybe even acne keloid alstinate. So we're learning. We don't know all the answers yet, but absolutely. So that's why in seborrheic dermatitis, we do treat with anti-yeast treatments, so zinc and ketoconazole, that sort of thing. So absolutely, it does play a role.
Great, thank you. I'm going to turn back to Dr. Delova. This is really a question about hair care from the audience. When would combing of the question is for African American, but let's expand that to anyone with Afro-textured hair. When would combing be best, wet or dry?
Well, when the hair is wet, the water acts, it breaks the disulfide bonds that combine the keratin. For the hair, it's better to comb the hair when it's wet because it's not going to break, or you moisturize your hair. Sometimes people just use those misty sprays to try and soften the hair. So the answer to that is when it's wet, because there's less friction between the hair shaft.
And Amy, Dr. McMichael, do you have anything to add about?
I would agree with that. Yeah, I would agree with that. I think, there are really pretty good detangling products out now, and some of them have dimethicone in them. They have other things in them, and I think that those detangling products, when your hair is wet, can be very helpful. So I agree. Wet hair with a detangler if it's needed.
Okay, thanks very much. And I'll stay with you, Dr. McMichael, for this next question. Any improvement with oral minoxidil for traction alopecia specifically? And you can expand on other disorders too. Go ahead.
Yeah. So oral minoxidil really has come into our practice armamentarium in the last couple of years, thanks to Dr. Rod Sinclair, a hair disorder expert in Australia. And he really described it talking about pattern hair loss. And so that's where it's probably gotten its biggest use. I think that there may be a role for it. I think in those who cannot tolerate topical minoxidil because of irritation, that I think would be a reasonable option to try. If you've gotten nowhere with topical minoxidil and people are using it regularly, I'm not so sure would be a great help. You could try it, but that might be a signal if you've gotten no improvement that the hair follicles have moved to the place where they can no longer grow hair or may actually be completely damaged. So you can certainly do a trial of it. I'm not so sure that it's going to be as helpful as it is in our pattern hair loss patients and even in our alopecia areata patients.
Okay, thank you. So we have a question for Dr. Delova, and that is there any role for PRP, platelet-rich plasma, for the treatment of hair loss? But why don't you start with scarring alopecia? Is there a role for PRP in scarring alopecia?
Well, I think so. I have a number of patients that have actually tried to use PRP. I think I showed a picture there with traction alopecia. But I think for it to work, you must have some background hair that you are trying to stimulate. If your scalp is shiny and there's loss of follicular ostia, I don't think the response would be great. Same with lichen planopilaris. I have tried it on some patients and I've seen some good response where there is some residual hair. So that's my experience, but it's obviously anecdotal. I haven't published any of those.
Yeah, and if I could just jump in and say, Dr. Crystal Agu has published case series on central centrifugal cicatricial alopecia with PRP and showing that it can work. But again, I would echo Dr. Delova's comments that what you're doing in that case is not, making hairs grow that aren't there. What you're doing is you're rescuing the hair follicles that maybe are sitting under the skin, kind of decide if they're going or coming. They can't really tell. They're inflamed potentially. So maybe some of those growth factors are, helpful for those hairs. But you got to have hairs down there to grow if you're going to be treating a scarring alopecia with PRP. And it can be helpful in some cases, and in some cases it just isn't.
I think we have time for one last question. This has just come through. One of our audience members would like you to comment on the use of JAK inhibitors in scarring alopecia. So Dr. McMichael, would you like to take that one?
Well, that's a hard one. I will tell you that I have very little experience with JAK inhibitors, personal experience with JAK inhibitors in scarring alopecias. However, there is data on lichen planopilaris with JAK inhibitors and very little, but there may be some improvement with that. So one of the things that we can see is folliculitis decalbans, for instance, might be something where you have a lot of inflammation, very localized, but there's a lot of hair still remaining. I think that, JAK inhibitors are great for a lot of things. They do work on that sort of JAK-STAT pathway. Our immune system is huge. And when you're dealing with a JAK inhibitor, you're going down that one small part of the immune system. And I'm not sure that we're going to get a whole lot to shake out for scarring, forms of hair loss. Lots more work to do there, I'll say.
Okay, and this is appropriate. This last part of the question literally is, in South Africa, few dermatologists have used tofacitinib 1% solution typically with success. So I'm going to turn to you from South Africa, Dr. Delova. Do you have experience using tofacitinib solution?
Nope, I don't have. I'm sorry. No, I don't have any. Sorry.
Okay. Well, the time has just flown by, and I just want to make a few remarks. Mostly, just thank you all for all of you who have taken time out of your schedules from around the U.S. and around the world to join us in our program today. Thank you to the panelists for sharing their expertise today. I want to also remind everyone that our next session in this series is pigmentary disorders and keloids. This will take place on Thursday, November 18th, and you can register for that session or any remaining session at the link on the screen. As you leave today, you'll see a survey. Please fill it out and let us know your feedback. It is very important to us as we plan future programming. And again, thank you all for your time. Have a great rest of your day. And thank you to all of our supporters, Visual DX, New England Journal of Medicine, and the Skin of Color Society. Take care.